to a webinar. We are talking today about soft indications for menopausal hormone therapy, or all those other things that people come and talk to us about in the perimenopause and menopause. And I am thrilled to introduce one of our two speakers. The other one will be back in a minute. Dr. Yashika Dooley. She's one of our medical directors at Genève. Shika, you want to tell everybody a little bit about yourself and sort of what we're going to cover tonight?
Yeah. Good evening, everybody. My name is Yashika Dooley. I am a urogynecologist, but I also specialize in menopause therapy for women. And I'm one of the medical directors here at Genève. I've been with them a few years and just really excited to be able to talk with you all about these soft indications. Of course, we all know women come with the vasomotor symptoms and all of that, but it's these soft indications that I think that are often a little bit of sticklers, especially when this is the primary thing that they're complaining about. And they're like, yeah, but it's, my brain fog that's really bothering me, or my sleep that's really bothering me. I have, those hot flashes or whatever, they're kind of on the side. And it really sometimes makes it harder for us to decide what to do. So I'm really excited for us to kind of talk to you about that. Also talk a little bit about the 2022 NAMS position statement. And just give you a little bit of evidence there as well, and kind of just talk about the way that we practice here at Genève and some of the things that we are talking to our patients about, and especially what they are seeing on social media, because that is really what they're also bringing to us, and it makes it very challenging to kind of meet them where they are when we're kind of trying to make all of those things work at the same time.
All right, now here's the big test. Wendy, can we hear you now? No.
No. But we could read your lips.
Yeah, I don't know if we want to read lips.
I'm hoping so.
Well, let's you and I start talking, Ishika, while we troubleshoot Wendy again.
Okay. Now I'm on my phone. I transferred it to my phone from.
And now we can hear you.
Okay, good. Okay.
We're getting closer. Can we get video from your phone?
Probably not if she's dialed in, or is it going to work?
Well, we may just have to deal with a W. That's okay. I think your words are more important than your face. We've all seen who you are. So I'm going to let the two of you take this away and talk all through things. But the other panelist I wanted to introduce is Dr. Wendy Satmari, who is also a Genève physician. Wendy, can you tell everybody just a little bit about yourself, and then I'll let you and Yashika take it away.
Yes, absolutely. I'm sorry. I can see you on my phone, but the volume isn't that great. Let's see. That might be better. But yes, I am a board certified OBGYN physician in Los Angeles area, and I've been in practice for over 22 years now. I did my undergraduate degree in kinesiology at UCLA, and then also medical school and residency in OBGYN, and then spent most of my career doing full scope kind of bread and butter obstetrics and gynecology, delivering babies, obstetrical care, surgery, clinic, and so forth. And over the years, I developed certain areas that I was more interested in and got additional training in things like chronic pain, vulvovaginal dermatologic and other conditions, menopause, and then more recently, lifestyle medicine. So during the course of my career, I was able to work with students and residents, do a lot of teaching and publishing. I enjoyed that. And then I kind of slowed down and eased into early retirement. And I did a few things after retirement that were interesting, working with some startups or as a medical advisor. And now I am working part-time with Genève for the past few years as a menopause telehealth specialist. So I'm happy to be here.
So fun. Well, let's dive right in. And so I know one of the big things that patients often come to us with are these soft indications, right? And so we kind of know the, FDA approved indications where they're coming with moderate to severe vasomotor symptoms, or maybe they are coming with genitourinary symptoms, right? We know like the big four, but when we're talking about these soft indications, Wendy. And, let's start, really just talking about brain fog. I think that's one of the big ones that a lot of our patients kind of present with. And especially when they are busy, they have high-powered careers and they feel like this brain fog is weighing them down. Can be very distressing. Talk to us about like kind of how they present to you and how you are talking to patients about this and taking care of them.
Yeah, it's definitely something we hear a lot. Is one of the common complaints. I think most commonly the vasomotor symptoms, night sweats, daytime hot flashes, the vaginal symptoms, and but also brain fog. And brain fog, I guess, can occur on its own, but in my experience, it's kind of more often in constellation with other common menopausal symptoms like sleep disruption, vasomotor symptoms, but brain fog itself is thought to be it's kind of a self-limited, very common and normal time frame in the perimenopausal period where one has kind of word finding difficulty, might kind of enter a room and forget why you're there, misplace your keys, forget the name of your street. I mean, I think we've all been there, and it can be very distressing, and be a negative quality of life, and parts of negative quality of life, but um, like I said, it's not necessarily in and of itself, by itself, a standalone indication for menopause hormone therapy. So if there is sleep disturbance with night sweats and brain fog, then that is kind of a no-brainer. It makes sense to go ahead and start for those symptoms because there's good evidence to support that. Most endocrine, I mean, most OBGYNs, our society, Menopause Society, International Menopause Society, doesn't really endorse menopause hormone therapies only for brain fog. But it's something that we talk about kind of more in the context of other symptoms that may or may not be present. Also in the context of kind of what we know from the literature, what are, solid indications. And, also if there are other things that are present that similarly are kind of soft indications that might cumulatively be enough of a reason to use menopause hormone therapy. I think it's really an individual decision with the patient and the provider.
And what do you usually tell your patients? Like, so when you're starting them on medications, what are you telling them that they might expect as far as their brain fog, or how do you talk to them about that? Or is it more wrapped up in when we take care of these other symptoms, the brain fog might also lift?
Exactly. Yeah, no, I mean, I think that for a lot of patients, I think in the back of their mind, they're really thinking, oh my gosh, is this dementia? Maybe, I had a relative who had dementia, Alzheimer's disease. And so it's really important to kind of reiterate and share what we know about the fact that it's not considered a pre-Alzheimer's or pre-dementia, that it's really a separate entity. However, for patients who are really having a lot of symptoms, and that may warrant further testing. Alzheimer's in that kind of cognitive decline is not really that common in the perimenopause. So I think a lot of reassurance in that regard. But then in terms of the symptoms of menopause that we may be treating with, let's say, for example, menopause hormone therapy, usually once we start that, I would expect to see an improvement in sleep and vasomotor symptoms within the first weeks or months, and therefore also an improvement in the brain fog. And usually, especially with new starts, we'll schedule a follow-up and discuss kind of a symptom diary, how the patient is feeling and so forth. But like I said, if it's kind of more an isolated brain fog, you'd have to think about other medical problems, comorbidities, or cognitive conditions that might require more testing, even ADHD in the postmenopausal period. So that's a little trickier to test for. The screening's more complex, but as part of our evaluation for menopause, since these symptoms are so common, we also do some testing for things like depression, anxiety, which can also be related to brain fog.
And I know you said a little bit specifically about sleep. What do you ever talk to them about? And I sometimes hear my patients saying, they're just so exhausted. And I sometimes kind of describe it almost like, their brain fog may be very similar to like when you're post-call, where you're just so exhausted you just can't think.
Yes.
And it's just, or it's hard to put sentences together, or your brain's not thinking as clearly, right? And so sometimes it may be you feel like you're walking in a fog, but it's kind of like that post-call feeling where I've just been up so long, my brain is so overwhelmed, I'm so exhausted that I'm just not thinking clearly. And that's another way that I kind of often talk to my patients when we're kind of, trying to figure out exactly what is going on, and is it maybe more related to their lack of sleep that's causing or exacerbating how they feel like they're having problems figuring out their words, or they go into another room and they forgot why they were there, as opposed to, you know, I just can't remember anything. Because I think a lot of people get very scared, especially if they have family members who have had dementia, that maybe that's where they're headed.
Yeah, exactly. No, I think that there's pretty good evidence that starting menopause hormone therapy should help with vasomotor symptoms that might be needed titration of dosage, or considering a different medication. It doesn't necessarily have to be menopause hormone therapy. There are non-hormonal treatments too for vasomotor symptoms and sleep disturbance. But what's interesting about the menopause hormone therapy is that it helps with sleep because it helps with the vasomotor night sweats, but also it works directly to help with in the sleep centers in the brain, kind of independent of the vasomotor symptoms. And we kind of see that more in the earlier perimenopausal patients. Um, so yeah, I think that, and again, many of the patients are coming already having had basic labs, complete blood count. Let's look at your CBC. Are you anemic? What's your ferritin level? TSH, other basic testing we want to make sure is on board and normal. I mean, one thing that's so significant about the sleep disruption in and of itself is that is known to increase the risk for cognitive decline in Alzheimer's disease. So that, among other things, also
Yeah.
metabolic disease, cardiovascular disease. So I feel like of the pillars of health, especially in perimenopause, when we have these sleep issues, that is something that's such an important cornerstone to tackle.
Definitely, definitely. And I think one of the things that, if you look back at the 2022 NAMS position statement, they do talk about the use of specifically in cognition, like if you start menopausal hormonal therapy or the use of estrogen therapy for the cognitive benefits in women that have recently had like a hysterectomy with the bilateral oophorectomy. There are some large randomized clinical trials showing that there might be some benefits there. I think a lot of our patients, though, are really coming in more concerned about dementia, or they're concerned about Alzheimer's, especially if they have had that in their family, and really kind of allaying their fears, and really talking to them that there's not a lot of data specifically for those indications. But I do find that a lot of my patients have those other vasomotor symptoms, and I will talk to them about what it is helpful for when we start them on menopausal hormone therapy, and when it's not. I want them just to be very clear. I think also we want to set the expectation of what they can reasonably achieve, or what goals they have when they're starting estrogen and progesterone, as opposed to a lot of the misinformation or confusing information that they may be getting when they're listening to social media, which I think also makes it much more of a challenging conversation. But again, it's our job to kind of help them be able to advocate for themselves, but also have the right information, so that when we are starting them on medications, but also, I find a lot of patients that are wanting to increase their doses and they're looking for a specific effect, right? And if that specific effect is not achieved, they want you to continue to ramp up on their doses, and really being able to have that conversation with them about what is achievable through hormone therapy, and what we may not be able to do just by putting them on estrogen and progesterone.
Exactly. No, that's such a good point too, because that special patient population, the younger patient who's had the ovaries surgically removed, premature menopause, or premature ovarian insufficiency, also patients who naturally had the cessation of menses before age 40, those patients definitely have, there's strong evidence that supports placing those patients on menopause estrogen, progesterone, if there's a uterus, or estrogen alone if there's not, at least from that time until the time of normal menopause, which is like around age 52, and then reevaluate as to whether or not you're going to continue kind of electively based on symptoms and what you're hoping to do. But that decline at that age, or sudden cessation, especially early on, that's when you're going to start to see osteoporosis increase, and cardiovascular disease risk go up, and diabetes. So for those patients, it is important to have that conversation early on, and at that time, rather than 10, 20 years later, when you're past the point of menopause by decades, and in which case menopause hormone is not recommended for symptoms. If but that's a different population. But still, I think with the younger patients, sometimes they can fall through the crack, and that's really unfortunate, because there is so much benefit for those patients to take MHT cognitively, but also for other chronic conditions. But yeah, I think, as the evidence is evolving, perhaps there will be more indications that are really clearly evidence-based, versus some of these that we kind of call yellow flags, versus the green flags. But in particular with regard to brain and cognition. But there's some newer interesting books and about estrogen in the brain, and the Moscone menopause brain book. I think that's fascinating. But like, from that, in that new discovery of estrogen receptors in the brain, to the point where we're going to have research and information and randomized controlled trials looking at what we're treating and what we're trying to prevent, that's a ways off. So I think it's hard sometimes to get wrapped up in what you're reading about and seeing on the internet, and just put a stamp on it saying, okay, I need MHT for dementia or whatnot. So it's more complicated than that, but it's definitely an exciting time, I think, for this type of research. And but we still have to discuss with patients individually about what the risk benefit and kind of indications are. And that can change over time. Someone may be minimally symptomatic, but then have more vasomotor symptoms, or trying conservative lifestyle measures and doing fine, but then symptoms are worsening, and treatment is desired. So it doesn't, it's not a one size fits all, definitely, as you know. There's
Yeah.
so much diversity in each patient's menopausal transition. But these are things I think that do come up pretty regularly, almost every visit, I think.
Yeah. And I think also one of the things that can be quite challenging is how a patient presents their symptoms and what is bothersome to them, right? Because I've had women, they're like, yeah, I have lots of hot flashes, but I've had those for so long, that's not as bothersome as my lack of sleep. That's the thing that really bothers me. Or, my joint pain or my brain fog, that's the thing that really bothers me. And I think sometimes that also can be a stickler for some providers and physicians, because you're kind of like, well, if these are the indications, but this is the thing that really bothers them, and they care less about, these other things. It's like, how do you, kind of go through that? And it really is for that patient. What is impacting or most impactful for their quality of life, right?
Right.
And it's hard for us to categorize that. It's really up to the patient to say, this is what is impacting, or this is what's bringing down my quality of life, and this is why I want the medication.
Right.
And not having that prevent us from being able to see the person as a whole person.
Right, right. Yeah, and also I find that sometimes patients, you're right, have been suffering with vasomotor symptoms for quite some time, but maybe they were told they weren't candidates for MHT, or were fearful, or didn't want to take. But there's so many non-hormonal, FDA-approved medications and other treatments which may be helpful. So that's unfortunate. But yeah, I don't think patients need to, like for myself, I had pretty horrible joint pain. I had other symptoms as well, but I even remember back to that time thinking like that was my main symptom. And I think if someone didn't investigate thoroughly enough, or I didn't articulate it well enough, then they might just say, no, you're not a candidate. But, um, it just takes some time to get that
Sure.
history.
And so talking about joint pain, because I don't think we've talked about that very much, when your patients are coming to you, or when women are talking about joint pain, or they're, sometimes I have women that present and say, I woke up and my hip is hurting, or I woke up and my shoulder's hurting, or I have like this frozen shoulder and I've been evaluated and everything has been negative. And I often will have these people coming to me and saying they told me that I need to check my hormones. How are you seeing these patients, and how are they showing up and talking to you about their joint pain?
Well, I would kind of love if a provider said to check the hormones, because then that, to me, I would infer that, hey, they might think that a perimenopausal status is relevant in this context. But yeah, I think there's also a lot that you see written about things like frozen shoulder and how it's caused by menopause and so forth, but the data is really not supporting that causal nature. It certainly happens more in women, and it happens more in older women, similar to arthritis. Like osteoarthritis is the most common arthritis, and over 50% of patients, women have it. It peaks in the menopause years too, just another thing to add to the plate. But it and that's why I think that there's pretty good evidence about how to treat osteoarthritis and what to evaluate. And it may or may not be osteoarthritis. It could be an inflammatory arthritis, or something more significant like rheumatoid arthritis, which has other health problems. So some testing, usually in person, to palpate the joints, check the joints. This is obviously generally not done by an OBGYN physician, but there's an evaluation, and then oftentimes blood testing, and then oftentimes imaging. But yeah, I think if everything's negative, then oftentimes there could be pharmacologic management like NSAIDs and physical therapy or supports, things like that. And pharma therapy and non-pharmacologic therapy. But what's interesting too is, even though there were studies, like the Women's Health Initiative study showed that the arm of estrogen plus medroxyprogesterone acetate and the estrogen only, those patients actually had less joint pain while they were taking hormones. So, but that wasn't that was not one of the primary outcomes, but that did achieve, statistical significance. So it's not like there's it's not like there's no evidence. And also there's kind of a lot of research looking at estrogen's effects on the joint space, the cartilage, the bone, the ligaments. I kind of took a deep dive when I was really suffering from this, and made other changes too, like lifestyle and exercise. And because with menopause, we have not only bone loss, we have muscle loss. And so, any joint, whether it's hip, knee, back, etc., strengthening and improving muscle function and strength can be helpful for that. So, oftentimes if you're seeing a physical therapist for the hip pain, it, may even involve the muscles of the pelvic floor and the sacroiliac joint. So there are different assessments that can be made, and then a kind of a prescription for therapy if that's the plan. Even, it's interesting because there's more written, I think, about patients who are being treated with for breast cancer with aromatase inhibitors postmenopausally. There's a lot of literature about that aromatase inhibitor associated musculoskeletal syndrome, which is not uncommon, and it's a high reason why patients discontinue the therapy. And they kind of postulate too about the mechanisms related to estrogen and so forth. So it's interesting. And some of the medications that are recommended for that condition would be things like SNRI medication, duloxetine. Even in a nice review about this, I was reading that acupuncture was found to be helpful for this type of pain. So, those are really low risk treatments. And, if there is an improvement, like I said, there's not robust evidence, but in this case where patients are taking medication that causes these symptoms, it seems to be something that they supported.
Yeah, definitely. And I think this is so interesting because if you look at like the Women's Health Initiative or whatever, there was definitely level one evidence that showed that those women had less joint pain or stiffness when they had hormone therapy compared to placebo. And especially in women who, as they get older, we know that there is decreased bone mineral density, there is decreased lean muscle mass, there is increased body fat. These women are already complaining of being tired and exhausted, gaining weight, and now you add on that they have this joint pain. And so when we're telling them, one of the things that you need to do for long-term whole body health is to be active and to be walking and to be moving and to really, the goal would be to be putting on lean muscle. And they're like, I can't move my arm. I can't move my leg. It really is another thing that just impedes them from doing what they want to do. They want to lose the weight, but now they can't exercise or they can't really move the way that they want to do. And so it's just, for a lot of my patients that I'm talking to, it seems like one more thing that's kind of weighing them down and preventing them from hitting their ultimate goal, but they're also interrelated. They're like, I'm tired, I'm exhausted, I've been working all day, I'm running behind. I put on all this weight and it's even that much harder for me to even get to the gym or exercise or do any of the things that ourselves and our RDNs are telling them to do because they feel physically incapable. They're like walking around and just going from point A to point B is hard. And now you want me to put weight on that joint. It's almost impossible.
Right, right. Yeah, and it's frustrating because I think patients often feel dismissed that, well, you're having knee pain, it's because you're overweight and you don't exercise enough. And it's just very frustrating because the pain's prohibiting the exercise, and being unable to exercise and pain can lead to weight gain, and it's just a vicious cycle. But yeah, so I think that at least not being dismissive and kind of having this discussion and sharing the literature, and if they're already going to be taking menopause hormone therapy for some of the more common symptoms like night sweats, hot flashes, sleep disturbance, vaginal symptoms, protection for osteoporosis, then it's a twofer. I always say, well, this is great. Then we can evaluate how that's working, and if not, if it's getting progressive and so forth, then certainly more eval needs to be done. We can't just chalk it up to menopause, especially if it's kind of advancing or showing any tenderness, warmth, swelling. That could be something that's infectious or inflammatory and so forth. But we don't see that a lot, but especially in telehealth, your mind kind of wonders, well, could it be gout? Could it be RA? And occasionally it is something more significant. But I think just to have that conversation and to share the data goes a long way. And then also having that discussion about comprehensively about what the symptoms are, what bothers them most, and kind of what risk benefit with each treatment type, whether it's hormones or the non-hormonal treatments, can be a start. And then in terms of, yeah, getting back into healthy eating, weight loss, diet, exercise, that's hard. It's overwhelming. And I think, as you mentioned with Jenna, we have our registered dietitian nutritionist who can kind of do that one-on-one support and guidance, and kind of also be there for accountability, which I think is really helpful, and kind of make realistic goals, not doing everything at once. Um, and patients can often gain 10 to 15 pounds in the perimenopause transition. So it's not going to come off, overnight, but it's kind of a time to reassess and really all of these things and kind of make good health choices moving forward. I think it's great we have first patients who are interested, and it's appropriate medication weight loss in addition to working with the dietitian one-on-one. So that would be kind of a joint program with the doctor and the therapist. I think that's wonderful for patients who that makes sense for. But yeah, I think that we need to have options, kind of realistic options, achievable goals for patients, so we're just not stuck in this kind of painful, inactive, kind of depressed situation.
Yeah, definitely. And one of the things I always talk to my patients about is, these things may not be completely cured, these other kind of soft indications. But while we're taking care of your vasomotor symptoms, while we're taking care of your, genitourinary symptoms, and we're starting you on this medication, especially if they've never had an evaluation for sleep. And, like I had a patient that was, she said her kids were always complaining that she snored really loud. I said, well, have you been evaluated? Have you had a sleep evaluation? Because yes, you're exhausted. And some of it may be because of the menopause, right? But I don't want to completely rule out that you could also have sleep apnea. There could also be something else going on. And if you haven't been evaluated, and those things haven't been ruled out, then I just always make sure that I am following up with them, or I'll be telling them these are the other things that I want you to also be doing. If your shoulder has never been formally evaluated and you think the joint pain is due to your hormones, but I also want you to make sure that you are having that evaluation, and I make sure I kind of am writing it up in the chart and then asking them about it. Just to kind of follow up and see where they are, and also just letting them know that if things aren't changing when I'm following up at your 3-month appointment or your 6-month appointment, and that pain is still there, that I am not recommending that we continue to go up on their medications in the hopes that we're going to be able to cure some of those soft indications. And I think, again, really just setting those expectations with the patient about what the hormones can take care of and what they can't, because I think they hear so much on TikTok and the internet, and when you're going on, Google even, and people are now chat GPTing everything, that it is really about making sure that we're giving them the information. And I usually really break it down. I'm like, these are the FDA indications. Some of these other things are soft indications. There is, is there evidence or not? And kind of just having them understand exactly what the medication most likely will be able to take care of versus some of the other things that may get better. Because a lot of the patients come with, I have itchy skin, or I have increased GERD or reflux, or, lots of these kind of things that they've been told all of these things should get better if their hormones are balanced, right? And so it's always an evolving conversation where you want to make sure that the patient has the knowledge that they need so we can take really great care of them, but also, again, balancing those risks and those benefits.
Exactly. Yeah, the check-in is so important. And also, like you said, being realistic about what our goal is with each treatment that we're using. And yeah, it's not, over time, usually at the 3-month follow-up, things should be moving in the right direction. And if not, then it may be time for further workup for some of these other kind of non-gynecologic kind of soft call, like the joint pain and so forth. Certainly sleep evals, I think, Menopause Society also endorses a need for having, not just attributing it to midlife, but also being evaluated for sleep apnea, because again, of all the significant adverse chronic medical conditions that can result from it not being treated and recognized.
Yeah.
So I think it's easier now to get those assessments, fortunately, often in the home, not needing to sleep in the center, but that would be up to the clinician. Some people like the wearable devices. I love my Aura Ring. I wouldn't use that to diagnose sleep apnea, but it can give you some insight too into kind of lifestyle changes as to why, perhaps you didn't get good sleep, if you stayed up too late, you ate close to dinner, you had any alcohol, you exercised too much, anxiety, stress. So
Yeah.
it's kind of nice to be able to track that. And it feels good when you make changes and you see the results. And of course, you feel great. So you want to kind of keep that up. It's more complicated than just a pill in many cases. But yeah.
Yeah. No, and I think it's great that you bring in those lifestyle changes, because I think sometimes, like you said, it's more complicated than just a pill. I think, giving them the hormone replacement therapy can be very helpful. But when people have developed really bad habits that contribute to their lack of sleep or the other things that are going on in their world, also making sure that we are talking about those things, right? Because those do have an impact. And if they are staying up all night or on their screens or doing all of these other bad habits that they've developed, it's hard to combat all of that, especially with whatever other circumstances and natural stressors that are happening in their day-to-day life.
Right. Yeah, exactly.
So I wanted to leave a little time just to make sure that if there are questions, it's about 7:45 here. I'm not sure. Let me look in the chat. I don't know if there are any other questions. I want to make sure that we can address those. Or if there's anything else, Dr. Satmary, that you wanted to discuss as far as soft indications or other things that you're seeing in your patients in particular, or ways that you're addressing those when you're talking to them.
I think we covered kind of the common, more popular ones. I think you've had some other sessions kind of more advanced on things like, other kind of medical benefits. But, I think that we have estrogen receptors from head to toe. And, clearly there's an effect on other systems other than just reproductive. And, it's interesting, some of the conditions that can increase after menopause are pretty diverse, relating to GI, to lipids and things like this. So I think that, just listening to the patient, trying to do some good screening, and then listening to the patient specifically about the symptoms, and kind of coming up with a plan based on that is really, paramount. But and also trying to provide education during the visit, and also through the Menopause Society. They have some wonderful handouts. They have something called Meno Notes. They have some good literature there. Even the International Menopause Society has some good handouts. And these are things that can be takeouts for patients, or you can have in your exam rooms if you're seeing patients in person. Um, and of course, some of the podcasts, the overreactive podcasts, I refer a lot of patients to those topics, just to kind of take a deeper dive in areas that we maybe didn't get a chance to cover as much.
Yeah.
But yeah, I think those are the big ones, I think, that we kind of outlined.
So one of the other things I was going to talk about is, and I know we had talked about previously, is how a lot of women come to us. We talked a little bit about weight, but in particular about like metabolic syndrome and diabetes. So I know we talked a little bit about weight and like body composition and our patients coming to us and really feeling like that's a problem. But how do you usually deal with that, or as far as like in particular menopause hormone therapy and metabolic syndrome and diabetes?
Yeah, I mean, I think, the way I explain it to patients about kind of why this weight settles around the midsection, and also intra-abdominally around the visceral organs, the visceral fat, is thought to, it's not 100% clear, but it's thought to be related to the dropping of estrogen, and also then the dropping of our bone mass, bone and muscle mass, and therefore our metabolism. So, like, the lean body mass is linked to the metabolism. Then also midlife, experts say, well, gosh, menopausal women, perimenopausal women are less active. So that's just a perfect storm for the setup to increase risk for diabetes, cardiovascular disease, all those things. So taking estrogen isn't like a magic pill, like, oh my gosh, it's going to fix all these things. Although, since sleep disruption is also a driver of weight gain through the perimenopausal period by its effects on other hormones like cortisol, ghrelin, things like this, it can, certainly help with that, and perhaps kind of attenuate like future weight gain in general. For women who have their ovaries removed early and have a surgical menopause, there is some data to support using estrogen, and those patients that may help with diminish the weight gain. But I think for all patients, it's also not that simple. But I think it kind of helps to understand this mechanism, because for most patients who are bothered by this, they often say something to the effect like, I've never had a belly before. I've always eaten this way, exercised this way. I'm not changing anything, and this is happening. So I think to keep it in context, to kind of explain what's going on physiologically, and then kind of what the Menopause Society guidelines are, can be helpful in that
Yeah,
regard. Good to have a lot of options.
definitely. Yeah, I mean, and we know definitely from the NAMS position statement that there is level 1 evidence that shows that when women are on uh, hormone replacement therapy, it significantly reduces their diagnosis of new onset type 2 diabetes. And so, there are lots of other things that definitely happen as women are putting on weight, going into the perimenopause and postmenopausal period. A lot of them will talk about, my hemoglobin A1C is increasing, or I have this central fat distribution, which they all hate. But also a lot of them will come in and talk about, all of a sudden now my doctor's telling me that I have high cholesterol. And so I think this is another great thing that we can talk to them about, because what they present oftentimes is with the weight and the belly fat. They may or may not be talking to us specifically about their hemoglobin A1C, but I think this is a great thing for us to be able to talk to, especially when we are looking at women who have had other issues. And so it's a great way for us to be able to bridge that gap for them. I have a lot of women coming in and saying, my doctor wants to start me on medications. I don't want to be on medications for high cholesterol or hypertension or, whatever. And so this is one of those things that we can talk about, especially in women who have maybe pre-existing conditions, like say if they have PCOS, or if they've had other, if they have been, borderline diabetic, or if they have a strong family history. I think this is another great place where we can kind of talk to them about the benefits of being on menopause, and how it's another way that their bodies can benefit in addition to those kind of 4 standard FDA recommended recommendations.
Exactly. Yeah.
You guys are so great. Thank you so much for this. I wanted to come on camera and just ask, if anybody has any questions, you can put them in the chat or the Q&A. I want to give one last shout out for any questions. Oh, someone came on camera. I don't think they meant to. You guys have been wonderful tonight, and thank you for talking through some of this. I think this is, like you mentioned, this is often the thing that people are actually coming in with. They're like, yeah, I have hot flashes. I knew I was going to get those, but I was not expecting
Yeah.
X, Y, and Z. And just being able to sort of go through all of those symptoms with women and talk about, where might the hormones help and where might they not, and what other things do we need to think about is something that we all need to learn and do better with. I am not seeing any questions in the chat, so
I see somebody raising their hand. They came on screen.
yeah, but we can't unmute anybody, so you got to type it in the chat. I'm sorry.
Oh, it looks like she unmuted herself. I don't know.
Okay.
Can you
did something
talk?
different. You unmuted. Go ahead.
Can you
Go ahead.
can you hear me?
Mm-hmm.
Yeah, you can.
Okay, great. It worked. Okay. Just as a brief synopsis of the whole thing, if a patient is coming in just for these soft indications, that is not an indication to start menopause hormone therapy. Just in and of those soft indications. Am I, or did I, because there was a lot of wonderful information and I'm just trying to boil it down.
I think
I will talk to them about the risk versus benefits. I will start them just for soft indications. I often think that a lot of times they have other things going on and they don't really realize it. I mean, even like genitourinary symptoms, unless you are really digging, a lot of women won't bring it up. And so I think there's a lot of things, unless you're having a very detailed conversation and really asking very specific questions to get the answer that you want, if it's not the main thing that bothers them, they're going to push it aside or poo-poo it. And so just because that's not the thing that they lead the conversation with is not, I won't tell them, okay, well, you don't qualify for medications.
Yeah, and I think it's always that risk benefit discussion, right? You have to say, here are what the FDA says this hormone can do. Here are some of the other symptoms of menopause it might help with, but we have less evidence. And you just have to be very clear in your counseling with them. Especially, I think you guys did a great job discussing brain fog. And brain fog is one of those ones where it's like, yeah, it might help, but it might also not help. And some of that's going to go away on its own. And it's a very nuanced discussion. So I don't think we're saying, I am like Yashika. I am I'm not in the never for this, always for this camp, but making sure that they understand what we have evidence for and what we don't really have evidence for, and what it may or may not help, and where they are on that spectrum is really. So we're not giving you an absolute yes or no. We're saying maybe.
Yeah.
Yeah.
And I'll talk to my patients and say, we can do a trial. Let me
Yeah.
try something for 3 months.
That's
For
a good
3
idea.
months.
And then
Yeah.
have you come back in 3 months. And these are the things that I want you to pay attention to over the 3 months so that when we come back, we can have a better discussion about how is this and how is this? Because oftentimes they'll be like, I didn't even realize that I wasn't doing that. I didn't even realize how bad this thing was until it wasn't there, just because it's become their new normal, right? But
Yeah.
if a patient comes back and they're like, nope, no change at all, I'm not going to continue to escalate medication just because I'm like trying to be like, well, if we go on a higher patch dose, maybe we'll get it. Like that's when I'm like telling them that's not what we're going to do. We're not going to be chasing it, but we can do a 3-month trial and just see where you are when you come back.
Yeah. I
Thank
generally,
you for that synopsis.
yeah, I mean, if patients are counseled appropriately and they're really having symptoms and they're in the right age for menopause and, have been told really no osteoarthritis, I think it's certainly worth a try because we have evidence, the WHI data showing that symptoms did get better. And I think it's just also important, like we said before, just to dig really deeply to find out if there are other indications that would lead you to support that decision. But yeah, I think if there are no contraindications, it's really low risk to try for 3 months and then reevaluate. Absolutely. But like Shika said, sometimes I see going up and up and up and two patches and,
Yeah.
that could be doing some harm. So we don't really want to go down that path.
Well, thank you guys. You did such a wonderful job, and thank you all for attending. Sorry about the blip of technical difficulties at the beginning, but I think we had a really robust discussion, and we hope to see you next month for the next webinar. We're working on a system where you can sign up just indefinitely for all webinars. So we will continue to work on that, hopefully have it up and running for the next month. But good night, everybody. Thank you for attending.
Thank you.
One last question popped in. Do you guys consider any transdermal dose too high?
Too high.
I mean, I think any of the patch doses available are relatively low potency.
Low.
And so I especially in perimenopause, I personally often use the 0.075.1. Especially if they're sort of end perimenopause, early menopause. Where I think you might be referring to is when we get these people who've got like 2 patches on their hips and 1 on their shoulder and they're getting like 0.3, then we're getting into higher territory. But in general, any of the patch doses available are totally reasonable to use. I don't know about you guys, but I often see patients who come to me and they're like, yeah, I started hormones, but it didn't really do anything. And I say, what did you start? And they say, oh, a 0.025 patch. And I wore it for 3 months. I'm like, yeah, that's what I use my 80-year-olds. You need to give them enough to treat the symptom. So I personally, I generally start at the 0.05 and reserve the smaller doses for people I'm mostly just treating osteopenia or who are older.
Yeah, me too. I would agree with that.
Yeah, especially younger patients or premature ovarian insufficiency, they are going to need higher doses. Really symptomatic young perimenopausal patients, even with increased depression symptoms. So those tend to higher doses. But yeah, I think the older patients, like you said, can often later when they're less symptomatic, it's more for preventing osteoporosis, then that can be a lower dose. I think even in the lowest dose is shown to be FDA approved for like 0.014, very tiny. So I don't know if that would help significant vasomotor symptoms, but I'm glad it has a use.
Yeah, definitely.
I agree. And we didn't really address premature ovarian failure here. That's kind of a totally different treatment pathway. And maybe just you having said that pings in my mind, we should probably do a webinar on that as well, because it's a totally different pathway. All right. Good night, everybody. Thank you so much for attending. And thank you for the wonderful questions. And thank you to our wonderful presenters. Yay.
Absolutely. Thank you. You all have a good night.
Good
Bye-bye.
night. Bye.